here has any sort of issues with their lower extremities? Hips, knees? Okay. Good. All right, so I want to go over, so this is this huge syndrome that's happening across the world, and it's called the falling apart syndrome. So we're going to cover some things as far as the lower extremities. So when it comes to lower extremities, we're looking at the low back, hip pain, knee problems, leg pain, ankle issues, and foot problems. So what they all have in common are joints. We're going to describe a little bit about the anatomy and physiology of a joint. So when you look at the upper extremities, and we're only touching on this, is that everything from below, from your feet up, is called a kinetic chain. So whatever happens down below is your body has to adapt all the way up. So when we look at this kinetic chain with the upper extremities, this is considered an open kinetic chain. And the reason why is it doesn't have stability. It's more open, it's more free. The lower extremities is called a closed kinetic chain because you have the ground as a foundation. So just some terminology that I want to go over before we get started. So when it comes to a joint, does anybody here know that joints do not get their own blood supply? Joints and discs do not have their own blood supply. What they rely upon, so when you see the bone and the bone come together, in between is cartilage. And cartilage acts as a frictionless motion and a buffer zone. The only way cartilage can get the nutrients it needs is through what's called imbibition. So around each joint, it's encapsulated, and this capsule is called a synovial capsule, and inside is synovial fluid. So synovial fluid is what gives your cartilage the nutrition it needs. Now, a very important thing about joints is unless they're moving, you're not going to get that fluid, that synovial fluid moving properly. So joints need to have proper motion through them. If they don't, that fluid doesn't get the circulation it needs, that motion, and it actually can start to dry up over time. Imbibition, that whole term means movement where on certain movements it's pushing toxins out of that synovial fluid, and on certain movements it's drawing nutrients into that synovial fluid, and that needs to be constant. So that's not just joints themselves, and that's wherever bones come together, you have your joints. It's also the discs of the spine. Anybody know that we don't have a blood supply to the joints? Okay, good. Okay, so what happens? So when joints line up properly, you will distribute the weight equally across that joint. But if for one reason or another those bones, the one above, below, or both, have shifted out of their normal position, two things are going to happen. One is you're going to start to create stress onto the cartilage. So one side is going to have stress, the other side is not going to have as much stress. But the other thing that starts to occur is now that lack of motion, improper motion, is not going to allow proper nutrients to get into the cartilage. But that friction, that's friction on top of the cartilage, the first thing that will happen instantaneously is lysosomes are released out of the cartilage. Now lysosomes, if they were allowed to continue, they would break down that cartilage pretty quickly. But what our body does is it then starts to lay down what's called fibrinogen. Fibrinogen is a dense like tissue. It's just similar to, you ever work out and you build up callus or you go barefoot, that friction, your body's going to try to protect that area. And it lays down more like collagen. It's more of what's laid down that makes up a callus. But it's a very similar activity that occurs to the joints, but it's called fibrinogen, which is actually very dense material. So the combination of that fibrinogen building up and that lack of nutrients going to the joint will start to break down that cartilage. So on average, research shows fibrinogen itself will lay down within 7 to 14 days. Just like if you were to go barefoot for a week on vacation, by the end of that week, you'd have a pretty good buildup of callus on the bottom of your feet. So 7 to 14 days, the body's going to lay down that fibrotic tissue wherever that stress and shearing is occurring. So that's arthritis. Arthritis is inflammation of a joint. As it continues to occur, eventually it starts to break down that joint. So what do all three of these conditions have in common? Have you heard of DJD, degenerative joint disease? There's degenerative disc disease when you're looking at the spine, and then there's osteoarthritis. All of them have biomechanical stresses that are occurring to that joint, but they're all considered a wear and tear arthritis. So DJD, degenerative joint disease, and DDD, degenerative disc disease, actually fall under the whole title of osteoarthritis. So there's other arthritis. There's immune system arthritis, such as psoriatic or rheumatoid. Those are autoimmune. For some reason, the body's breaking down that cartilage. This is completely different. This is a wear and tear arthritis due to what we talked about earlier. So when you take a look at the hip joint, here's that spacing. So on inside what's called the ilium, it's going to be covered with cartilage. Cartilage is going to go around that femoral head, and that's going to protect the bones. And then it's surrounded by fluid with that synovial fluid. Same thing with the knee. You're going to have cartilage on the bones. You also happen to have a meniscus, which is similar to a disc, only it occurs in the knee. You have a lateral meniscus, and you have a medial meniscus, and that's like a buffer, more of a buffer. And then it's all surrounded by that fluid. And even in your feet, every bone in your body, where it meets up with another bone, has cartilage with that synovial fluid inside. So we want to take a look at the SI joint. The SI joint is where it's for sacrum and ilium. So there's a left SI joint and a right SI joint. And those joints should glide. If you've ever seen a gyroscope, it's that kind of action. So as we walk and move, we have that. Now, it's not going to move to this degree, but there's movement that occurs every time we step, walk, and move around. So same thing, along that line, for those bones, you have the cartilage, you have synovial fluid. So here's an x-ray of an osteoarthritic joint. This is the ilium. So here's that spacing. Here's this spacing. There's actually a little bit more of a breakdown on this side, but both of them have some arthritis building up in that joint. If you look at that hip joint, you can see a better space over there, much less of a space over there. So this hip definitely has osteoarthritis. They're almost bone on bone. This one has arthritis, but it's an earlier phase of degeneration. Anybody have any questions so far? Okay. All right, so hip problems. So what we know is, so what causes bones to shift? That's the biggest question I get all the time. So there's many things that can cause it. Posture, doing certain activities the same way that are asymmetrical. That can start to retrain muscles and start to cause these joints to shift, the bones to shift and put pressure. There's other things that can happen, and I'll cover that a little bit later, with your feet. As we talked about this kinetic chain, whatever happens below, if that's shifting or you're starting to have fallen arches, it's going to cause the rest of these bones to react to that. And I'll describe that a little bit deeper. But there's a lot of research that shows that once you have, if your hips are on level, it can take, on average, about 20 years of stress on a joint before you start to see the effects on an x-ray, where you see the arthritis. Now that may or may not have pain, that person. I see a lot of patients come into our office, they're in what we consider a phase 2, where you can see the breakdown of the, you can see that spacing breaking down. So this one will be about a phase 1, late phase 1, starting to see some calcification, a little decrease to the cartilage spacing. That's a phase 1. Phase 2, you would see more bone spurs and a thinner spacing going on. So people may or may not have pain when it comes to arthritis. Awesome. So a little closer view as to what a normal hip socket would look like. Again, there's that nice spacing. Here's someone who's pretty advanced. We would say that person's into a phase 3, and there's 4 phases of degeneration. If I talked about the first 2, the third one is pretty advanced, the fourth one is bone on bone. Any questions on the hips?
What are the 4 phases again?
So phase 1 is a misalignment. During that phase, fibrotic tissue is building up, lack of motion in the joint, so that synovial fluid is starting to deplete in that area. It's not moving properly, so the cartilage isn't getting its nutrients. Phase 2 is where you start to see on an x-ray, you start to see a little bit of a breakdown. You also see a little bit of bone spurs starting to occur. Phase 3, you want to see a lot of breakdown. You're going to see a lot more calcification forming around that joint. And phase 4 is bone on bone.
Is there anything that you can take to increase the synovial fluid, or maybe you'll get to that?
Well, there are nutrients you can take. You hear about the different, like shark cartilage is good. Omega-3s are very good. Omega-3s are, I'll get into that, but omega-3s are anti-inflammatory. Omega-6s are inflammatory. So you don't want inflammation because that's part of that lysosomes laying down, and that's starting that whole effect. So now we want to take a look at the knee. The knee is so I'm sure everybody knew this, but this is a ball and socket joint. So there's different types of joints in our body. That's a ball and socket, so is your shoulder. It has the most range of motion out of any of the joints. So we just can move as much as possible. The knee is considered a hinge joint. It really mostly only moves what we call flexion extension. There is a little bit of rotation that will occur in the knee, but it's very minimal. So where the 2 bones meet together, you have the meniscus on each. They act as a shock absorber. There's cartilage that lines the bones, so you don't have synovial fluid. Now, different things can cause the knee to shift. And I will get into that because it starts at your feet. It can start at the feet. It's very common to start at the feet. But if your tibia rotates, often it can rotate externally, and that's where the bottom of your leg rotates outward. It'll create stress onto that meniscus, and that whole process starts to occur. Lack of motion and friction. So this is pretty advanced. We would say that one's like phase 3, leaning towards phase 4 right through here. Better picture, that's a very healthy joint. So one of the greatest things that I love to see on a patient's face is when we talk about arthritis, because everyone assumes as they age you're just going to have arthritis. But osteoarthritis is not due to the age of the person, it's the age of the stress that determines if you're going to get that wear and tear. I have patients that have come in and I'll check their neck. You know, I can have a patient that's been taking care of their joints for a very long time. They'll come into my office, they'll say, hey, I haven't been x-rayed in like 30 years, I've been getting adjusted for a long time, but I'd like to see what's going on. Because if I palpate them and they're not off much, I will not need to x-ray them. But I had this one lady in particular, and I took her x-ray, and she was about 74 years old, and she was great. She wasn't completely normal. She had a little bit of misalignments, and that just happens just with posture. But she maintained that, and she had healthy disc spaces. And I can have 20-year-old students come in, like college students we'll see, and they're already into a phase 2. So it all depends on the person, their activities, injuries that they may have sustained over their lifetime. So then we look at the ankle. Again, when we look at pronation, we look at normal, and we look at supination. It depends on which way, and it comes down to the arches of the feet, and I'll explain that in more detail, but pronated is where all 3 arches have started to fall and the foot's rolling in. When the foot rolls in, the tibia rotates out, the femur rotates in, and the hip drops. Supination is when the foot rolls out. But in all these cases, there is going to be stress put on different parts of these joints. And the longer it's been there, the more damage is going to occur. So here's a healthy joint. So this is the tibia, this is the spacing, and this is the talus, and that's a nice open space right there. That's a healthy joint. Here we can see, actually this tibia is rotating, and there's stress going on out in here. And over time, it just starts to break down. So now I'm going to, so we talk about the kinetic chain from the feet up. So when you look at the foot, there's 3 arches there in the foot. So this is the medial, this is the inside of the foot, this is the outside of the foot. So this is called our medial arch, our transverse arch, and our lateral arch. When they are healthy and build up, they create what's called a plantar vault. And the plantar vault is going to give arch to your foot. And the reason why we want arch to our feet, 2 reasons. One is it provides strength to our feet, but it also supports the bones in the feet into a neutral position. So when you look at the, it's going to be, I'll go around, but I'll just show you. The bones of the feet, when they're in a neutral position, when they're matching up, when they're matching up nicely and they're distributing the weight equally, your foot will have an arch to it. So when the bones are nice and equal, distributed properly, you end up with an arch in your foot. So that's going to provide support to your feet, to these bones of your feet, and it works its way all the way down. So if that's supported, all these joints are going to be better supported. Now, typically what happens with a lot of people is the lateral arch will start to break down. When that starts to break down, your heel, called the calcaneus, starts to roll in. When that rolls in, it creates a wedging in these bones right here, and it causes the tibia, when that goes this way, the tibia typically will roll out, which we call external rotation. So that bone's going all the way up to your knee. So instead of that sitting properly, it's going to rotate out. It's going to create more stress into that knee joint. And then what happens, because it's a kinetic chain, everything has to balance, work its way up. Then the femur rotates in, and this hip drops. That's a typical, most common situation when you see pronation starting to occur. So once that stress, that arch, that lateral arch starts to break down, now you're going to create more stress into this transverse arch and onto the medial arch, and over time, that can just continue to break down. As it breaks down, you lose that plantar vault, and it starts to roll in, and then you create stresses onto the bones, and you can also cause the feet to spread out where you're creating different ganglions and different things like that. Okay, does that make sense? So this is all about the biomechanics of joints. So because we are a living being, our body is always trying to heal itself. So part of this breakdown that occurs is there's just natural stresses that are occurring due to activities in our daily lives. And as this happens, that whole lysosomes laying down is actually a mechanism to try to provide fluid to an area, but over time it would break down that cartilage, and the body tries to protect that cartilage even better, lays down fibrinogen, which spreads out that degeneration more towards 20 years. Okay? So that's what happens to joints. So when it comes to knee joints, hip joints, foot joints, and there's foot pain, we're looking at that right away. We're going to look at the structure and see, okay, how close to neutral are these bones setting up? Now, one of the ways that you can measure the bottom of the feet and see how arches, if they've fallen or not, is there's laser now. They're awesome. We got one, what, about 2 years ago, a year and a half, something like that, and it's great. It measures, and it'll show you the impression of your feet onto this and how much of the arches are built up or not. And then we combine that to what we see as far as we'll check the knee, we'll check the hip height, and then if that's misaligned, we take x-rays, so you will actually see what the joints look like, what the structure looks like. Every structure I've ever seen where there's stress on those joints and they've been there a long time, you're going to see degeneration in those areas. Okay. so this is that whole kinetic chain that we talked about. The foot rolls in, the tibia rotates out, the femur rotates in, and the hip drops. And then people can compensate in different ways. So some people, I can have somebody with a real pronated foot, but then their left hip is dropped just because of activity, the way they've compensated. So it's not a set rule, it's just a common occurrence, but we're going to check it anyway to see what's going on with it. So if your structure, if you age like this, you are going to have less stress on your joints, and those joints will age nicely. As I mentioned, that lady who was in her 70s, she had one of the healthiest spines I've ever seen. And I've seen that more often, but that lady, early on in my career, and she always stood out. So those are biomechanical stressors that we look at as far as any of those pains. Because even, we're talking about joints, but all the joints are supported by tendons, ligaments, and muscles. So when those stressors occur, ligaments are going to work differently, muscles are going to work differently. So some of those symptoms can come from the muscle, some of it can come from the tendon. We've heard of tendinitis. But it's all about making sure that the joints are into a neutral position and moving properly. Good motion between the joints are very important. So there's biomechanical stressors that can cause symptoms and issues. There's also neurological stressors. When we're looking at neurological, we're looking at the central nervous system and the peripheral nervous system. So I'm going to give you, not to bore you, I don't want anyone to fall asleep, it's like 7, but I'm going to just touch base on the central nervous and the peripheral nervous system. So real basic, the brain and the spinal cord is our central nervous system. And the brain is what coordinates all function. There's nothing that goes on in our body that the brain is not in control of. So our immune system, digestive system, cardiovascular system, it coordinates and controls and regulates every system in our body, and it does it by sending nerve impulses back and forth down the spinal cord, out through the spinal nerves. Spinal nerves are where they exit right from the spine. It's considered a peripheral nerve. And from there, they branch off to every nook and cranny of our body. So spinal nerves connect all our skin, our heart, our lungs, our immune system to our spinal cord, and then our spinal cord connects it up to our brain. When it comes to the central nervous system, there's a thing, I don't know if anyone's ever heard of myelin sheath. Myelin sheath is a protective layer. It's not coated in the central nervous system. It's only coated on the peripheral nervous system. And there was actually a study that was done where they put pressure right outside of the spine onto a peripheral nerve and even further out, but right where the spine exits is what we call a nerve root ganglion. So a nerve root ganglion is at each level. So each spinal nerve exits at each level on each side of your spine, all the way down. So you have these nerve tracts that come down, and there's millions and millions of them coming down inside that spinal cord. When it stops, so that nerve tract will come out, it'll stop at that, which makes up this nerve root ganglion. And then from there, it's synapses where another nerve becomes a peripheral nerve and goes out this way. Each spinal nerve has over 100,000 individual nerve tracts, each one on each side. So when they put pressure outside of this nerve root ganglion, it could withstand a lot of pressure. When they put it on that nerve root ganglion, just the weight of a dime, which as it's measured in science is 8 to 10 millimeters of mercury pressure, disrupted that nerve transmission by 40% after 15 minutes. And this wasn't a one-time study. This was a bunch of studies, and this was the average that came back as a 40% loss of nerve transmission just with the weight of a dime, 8 to 10 millimeters. After 30 minutes, it lost 50% on average. So that's not a long amount of time. So what can cause this are bones. So we talk about all the joints down here that can move. The spine is a segmented joint. If you add the sacrum, that's 25 individual bones. And each bone of the spine has 4 joints. That is 2 above and 2 below. So when they meet, they have that cartilage. Then they're separated by discs above and below each vertebra. So that allows us to twist and turn and have a lot of mobility. But at the same time, because we have more mobility, we're also vulnerable for misalignments. So when a vertebra misaligns, if the vertebra rotates, we say to the opposite side, the canal, the channel where the nerve comes out will become narrower, become diminished. If it laterally flexes, same thing, combination of both will really decrease the space around that nerve. Now around each nerve, you have fat tissue and 2 blood vessels that come in. They will also get compromised. Okay, so the blood is going to the bone. That's the blood vessel, it's not going to the joint. So rotation, lateral flexion, combination will decrease that spacing, and depending on what part of the nerve it affects depends on if you feel it or not. So when we look at each one, say this is any one of those spinal nerves. You have a motor nerve portion, an autonomic nerve portion, and a sensory nerve portion. Motor nerves, we know the ones that come out of the neck go to specific muscles into our arms and our hands. Motor nerves out of our low back go specifically to muscles in our legs and our feet. Sensory nerves, same type of distribution, what goes to our arms and hands, out of the neck, legs and feet, out of our low back. Out of sensory nerves, you have vibratory nerves for touch, just real basic. If you interfere with the vibratory portion of the nerve, you get numbness and tingling. You have pain nerves, they only make up about 8 to 10% of this over 100,000 individual nerve tracts. Only 10% of them actually, their function, the sensory, is to perceive pain. And then you have temperature for hot and cold. The last majority coming out of the spine are called autonomic nerves. They're the nerves that control our blood vessels, our glands, and our organs. They're automatically happening. You never have to think about it. You sleep, whatever, they're always working. Okay, so depending, when there's a misalignment and there's pressure on that nerve, depending on which part, it can affect all 3 parts of the nerve, 1 part, 2 parts, 10% of a motor nerve, maybe 30%. Any combination can occur with a misalignment. The only time we will feel it is if it hits that pain portion. If you affect the transmission of the autonomic nervous system, you will never feel pain. But where it's going to, if it's controlling your heart rate, if it's controlling your bronchi, if it's controlling your digestion, that area cannot work the way it's supposed to because the brain no longer can control and coordinate back and forth with that area. Motor nerves, 2 things can happen. So when you interfere with that nerve transmission, you're either going to diminish nerve flow or you're going to excite that nerve. It's called facilitation of a nerve. It becomes hyper wherever it's going. So that it's going to a muscle, it's going to become spastic. If it's diminished, it's going to become flaccid or weak. Autonomic, wherever it's going, if it's diminished, that area can't function as well as it should, or if it's going too hard, it's going to be overfunctioning. Okay? So that's a nervous system. So the reason why we're talking about this is so what this is called, when there's a misalignment of the spine, it's called a subluxation. So it's a joint misalignment. Causes inflammation, causes soft tissue damage, which is that cartilage. Joint fixation, meaning it's not moving properly. Loss of inhibition, so it doesn't get the nutrients it needs. Around that area, it can have spasm when it's trying to guard it. The nerve gets irritated. The organ will not be able to work as well, just like the muscle. And then, depending on where it affects, we talked about the lower part of the spine. That's what goes to the lower extremities.
Can you go back to that?
Sure.
Okay, what about if there's been like, in a situation like with a burst fracture?
Burst fracture. Yeah, well, it depends on how it healed, in what position it healed, how long ago it healed. So if we have a bulging disc, say someone's had force to their disc and it's torn, because a disc is made up of what's called collagen fibers.
Right.
It's a matrix inside the nucleus called pulsus. It's like a ball bearing of the disc. If that allows that inside to start to go out, and if it goes towards a spinal cord or spinal nerve, it's going to affect that function of that nerve. So chiropractic isn't going to help everything. It's only going to make sure that if we're able to. So if someone has a disc, like we would work on a bulging disc, we would not work on a disc that's going out and drop down into the canal. We could never get it back up. So typically what causes a bulging disc is squeezing. So that bone has hyperextended, one or both, and it's creating stress, tearing, pushing that way. So as we open that up, that allows bulging discs to recede. And I've worked on many patients with bulging discs, but we'll get an MRI when we see those type of indicators suggesting it's possible bulge. As far as a burst fracture, if it's burst and now there's calcification all around that joint, we can't move those bones because they're fused, or we just don't know until we saw an x-ray. An x-ray will give us the information. They have a lot of neurologic indicators. Like I said, we would get an MRI. Any other questions so far?
At the bottom of the thing though, it says lower extremity issues, like what would that involve?
Okay, so that's gonna, right, perfect time.
I have one question about the herniated disc.
Sure.
What does a surgeon do when he actually performs that surgery?
So it depends on what type of surgery. So there's discectomies. They are the most successful surgery for a disc. I've referred patients, that's where either it's dropped really far back, that disc, into the canal, or it's dropped into the canal and then dropped down. What they do is they just cut that piece of the disc out, takes the pressure off, because that's where the spinal cord is running down, and that's where the spinal nerves are coming down. So they just remove it from there, and then it's allowed to heal without that disc there putting pressure on the spinal cord.
Just on the bulging side, or?
Yeah, just on the bulging side. They cut that portion out just to clear space and get pressure off the nerve and or spinal cord. Yeah, now, it's great, and that's great symptomatic relief, but if there's what caused that, if that spine is off and it's not moving right, it's going to become an arthritic joint. And over time, that it can cause the whole canal. So that channel where it comes down, if that disc continues to wear down, that channel gets small. That's called stenosis. You hear a lot about stenosis. That's osteoarthritis in its extreme. Phase 3, phase 4. It can happen in late phase 2, but that's what stenosis is.
So after you have that type of surgery, what would you recommend?
So I have worked on patients afterward. When it comes to a chiropractor, there's only two things we're looking at. We're looking at position of the joint. If it's misaligned, we want to take an x-ray. And most importantly, when they're on the table, we're only going to adjust the segment that's not moving properly. So when we take the x-ray, we know what we're working with, and if we can work with them. And then every visit is we're reestablishing better motion into that joint, breaking up that fibrotic tissue. That synovial fluid starts moving better, and that becomes a healthier joint, a cartilage. So we'll take 3 x-rays after a certain number of visits, and we determine the number of visits based on what phase of degeneration they're in. Because if they're in a phase 1, we expect that after a certain number of visits, that the joint, the bones are going to move towards neutral a certain amount. And we'll see on post x-rays from the lateral, we'll see this phase, and we'll see the disc start to open up. That's phase 1 and 2. Once you get into the latter part of phase 2, there is some regeneration that can occur. Phase 3, there's also a little bit of regeneration, but once you get into like quarter to halfway through phase 3, I'm not working on the patients because I just can't be effective. All right, so again, this is the autonomic nervous system that talks about where the nerves distribute to. So I'll have patients come in, very common, come in with low back issues, and they may have intestinal, like Crohn's disease, whatever it can be, any kind of intestinal issue. Now, we're not going to tell them we're going to get rid of that. We're going to see if they're misaligned. If they're misaligned, we're going to work on that to get it back into neutral and get proper motion. But I've had patients with Crohn's where they've had Crohn's taking 50-some pills a day, diminish it drastically. But they always go back to their medical doctor. And it's the same thing with allergies and asthma. We'll work on them, but we say check with your doctors and see. And I had a lady who was getting monthly injections for allergies for about 20-some, 30 years, and she just stopped after 4 months. She forgot her appointment because she wasn't having symptoms. So things like that can happen, but that's where you know. I mean, a subluxation, which is a misaligned bone, it's not preferential. I mean, it's not going to say, hey, we're just going to get the pain nerves. If it's hitting an autonomic nerve, it's going to affect the function of that nerve and wherever that nerve's going. So this is why we brought it up, because lower extremities, we want to make sure the neurologics are okay, because if that nerve that is going down into your knee, so you have your sacral spinal nerves, you have your lumbar spine, they just travel to different areas. So if you're affecting the sensory part, the pain part of that nerve, and it's going to the knee, I've had patients, they don't have any pain here, they could have here, we check their joint, it's moving pretty good, we don't see degeneration. We see misalignment here, we're going to work on the misalignment because that's what we do, and we've had knee pain go away that way. But we just want to make sure the neurologists are clear along with the biomechanics. Okay, so that can be feet, that can be inner thigh, outer thigh. So L3 through 5 is a big innervator that goes down into the leg, so is the sacrum. So that's here. So, drawing all these out for sissies. But there are ways to make it better, not just maintaining your spine. So, your skull protects your brain, your spine protects your central nervous system of your spinal cord, and then your ribs protect your inner organs. But all your joints is for motion. If you treat them well as you age, and you keep them in neutral, that cartilage will age nicely. As opposed to osteoarthritis, which is 80% of the arthritis, over 80% of the arthritis you find, like hip joint replacements, it's typically osteoarthritis. Now there are psoriatic arthritis and there's rheumatoid that can occur, and that's an autoimmune. Chiropractic adjustments are going to do it. They're going to help with motion in that joint if it's not moving properly with that synovial fluid, but it's not going to stop what's happening with the autoimmune system. So there's different things patients often ask as far as self-care. So if they're always like, ice or heat or ice. So ice is whenever there's inflammation. And typically most people are starting to get that information pretty frequently. So ice is to reduce inflammation in the joint. So as soon as an injury occurs is when those lysosomes are just firing. There's all kinds of fluid building up. So you put the ice on there, that disperses and pushes away fluid. Heat will dilate all the blood vessels, it will dilate going into that whole area, and it will bring more fluid in. So we want ice with inflammation, we want heat with muscle spasms, injured muscles. Because we want a lot of blood getting into that muscle, we also want to stretch that muscle, because so I talk about joints. Stress on joints creates fibrinogen, stress on muscles creates collagen. Now there's a combination of both, but primarily it's collagen in muscles, and it's primarily fibrinogen in joints. Collagen is more like a chewing gum. Fibrinogen is more, it's kind of gross, but you ever see a third-degree burn, striated? You ever see how dense that the skin tissue is? It's very dense. So fibrinogen is much more dense as opposed to collagen. But you want to stretch a muscle, you want to get motion through that muscle as it's healing, but you also want to get blood flow, because that's going to bring nutrients to the muscle. So heat is good when there's a lot of tightness, and you want to, but when there's a lot of fluid, you have to go with ice. Now there's also what we call subacute conditions. So ice would fall under acute. This is chronic. Acute and subacute, sometimes it's called contrast therapy, where you go 10 minutes here, 10 minutes there, and you go back and forth, and then eventually we'll stop with the heat. In the beginning, with contrast, we might stop with ice, because there's more inflammation there. There's actually spasm and tightness. There's other things you can do as far as breaking down adhesions within muscles, foam rollers, tennis balls, and then stretching is very important. Not overstretching, but good stretching, normal range of motion. And then exercise, of course, is good to help stabilize the joint once it's back where it belongs. So there are allopathic options: heat, bed rest, drugs, anti-inflammatories, steroids. They want to reduce inflammation. Physical therapy is great because they'll help strengthen an area. They'll do some. Well, they used to do a lot of ultrasound. They don't do as much of that as they used to, but they're doing other therapies. There's laser. It's called cold laser. That's phenomenal. You see all the professional athletes getting back on the field after using cold laser. What that helps is with cellular regeneration. It causes So I won't get too deep with it, but there's a thing called ATP energy. And ATP energy is what fuels our cells. It's like it's the gasoline for our cells. So the more ATP energy you can get into a cell, you're going to help that cell function, like it gets the energy it needs. So that's what cold laser does. It it increases the ATP energy at that area. So there's different things. Steroid injection, we thought surgery if you need it. The only thing with surgery is surgery will go to that specific spot to make sure that you're not having pain. But there is compensation that goes above and below that area. So it's good as far as joints. You want to make sure all those joints are moving properly and are as closely to neutral as possible. As I mentioned, you can do a discectomy. We don't know what caused this discectomy. It's usually, caused the herniated disc. It's not usually a blunt force. It's usually something that's happened over time and just the smallest thing just pushed it overboard. Or it could have been building up for quite a while and then all of a sudden now it's putting pressure on the sensory part of the nerve. So there's something that causes that herniation to occur, and that's stress. That's a biomechanical stress majority of the time. So when it comes to chiropractic, that's what we're looking at. We want to make sure that we're going after the cause, whatever caused this pain. If it's biomechanical, it's neurological, we want to see what's going on and just get things back into neutral. So basically, chiropractic adjustments improve position and motion of the joints, and it prevents the wear and tear, and also big, as far as hip replacements, shoulder surgeries, and then also improves nerve function to that area and that inhibition where you're getting nutrients. So everyone says, how do I get misaligned? So we talked about, so when we look at the hips, once the hips are off, the rest of the spine is going to have to compensate. Now there's different things that you can add to your upper back. Computer is killer. Texting is one of the worst things for the neck. There's all kinds of research going out about texting. You completely get all this forward head tilt. But this isn't an upper extremity, so there's different things that can cause it. So macro trauma is any kind of injury, like ski injury, major fall going down the steps. Of the conditions that occur, research says only 2 to 8% are causing these problems, these issues, these conditions. Micro trauma is majority. 95 to 98% of the conditions that we see in the offices is coming from things that are happening every day. So that kind of position, every day, in and out, looking at a computer, having that your mouse forward causes your scapula to roll forward, causes stress into the joints, causes tension coming down the neck because it's working with the joints and it's also working with all the muscles, tendons, and ligaments. So whatever we do on a regular basis will affect our body. Our body will compensate. So if you have bad posture the majority of the time, you're going to end up, and I get them in our office, and it's too late a lot of times. I have an older man. He's a really nice older man, and he's like this, and his head's here. So one of the things that we look at on an x-ray is we look at C1, which is your first cervical vertebra, and C7, your seventh. So when a person's standing what feels natural, ideally they should be right above each other. There should be a forward curve. What we see with texting is kids are like this often. Adults are like this. They're just texting, and what's going to happen is these muscles shorten, all the stress goes onto these muscles, and then over time this becomes a normal position. And so I'm doing x-rays. So I've been practicing 25 years now. Back in the day, forward head tilt might be about 12, 15 millimeters forward. I'm seeing on average 22 millimeters, 30. I had a guy, young boy, he's in high school, he was 61 millimeters forward. So his mom brought him in, he's been going to the neurologist, he's on all these meds because he gets all these constant migraines. But you look at his x-ray, he's standing, I always say stand what feels natural. So he's standing, he's doing this, his head's here, and it's normal. He's putting so much pressure on his brainstem in that position, which is not only affecting the nervous system in this area, but there's also all these blood vessels that come through your spinal column, which are going to impact blood flow. back up on the brain. So forward head tilt is not a good thing, especially extreme. But different things can cause subluxations. The majority of them are what we do on a regular basis. So we do go over that a lot when it comes to our patients as far as everyone, almost everyone's behind a computer. Laptops are not great, so what you do is you raise the laptop up, just have a keyboard and a mouse. But if you elevate, if you're on your laptop day in, day out, you're going to want to raise it, because if not, you're just constantly retraining your muscles to be in the wrong position. Just even posture, sitting at the desk. You're hearing a lot more of these called Versa desks where you're able to raise them. They're phenomenal for a lot of reasons. Posture is huge, biomechanics, but also just that pressure being up. Harvard did this study, it's good for our organ, it's good for circulation. So those desks are great. And who was that? There was an author down in Cuba. He always had a standing desk. He was a little crazy though, so I don't know if there was any effect. Was it Hemingway? He had a standing desk. But so these are different things that can cause your spine to change position. So it can just be everyday activities that retrains the spine to be in the wrong way, or the hips. Another thing that can cause hips to be misaligned is your actual, by the time you stop growing, you can have a different length of your right femur compared to your left, and your right tibia compared to your left. And there was a study that was done on 6,000 patients. 92.2% of them had some sort of leg length discrepancy. It's not as much of a big deal when you get, well, this guy says 2 millimeters is enough to create problems. But 3 millimeters is pretty much what the standard, they say just 3 millimeters off is enough to create that friction, causing that fibrotic tissue to lay down and that whole osteoarthritis to occur. So that's something that we do check. We see indicators. There is a way to x-ray, which is very low exposure to the body as far as x-rays, where you just x-ray across the ankle, the knee, and the top of the femoral heads with a metric stick behind it, and you can measure to the millimeter. It's the most accurate way to know if there's a leg length discrepancy. As far as creating change, all you need is a heel lift. So if you go up to 5 millimeters, where there's a difference of an anatomical short leg, 5 millimeters, you can put a heel lift in. Once it crosses over 5 millimeters, you don't want to have one foot that's flat and the other one that keeps raising, because it messes with the biomechanics, creates strain on the fascia, also messes with the bones of the feet and the arches. So that's when they raise the whole shoe. So you there's a great guy close by. I'm always plugging him because he's the only one in town. And people from Delaware all over. What's his name? Do you know? He's right over here, the shoe cobbler.
Mm-hmm. Starts with a P.
Pisano.
Yes.
Yeah.
Yeah, Pisano. So he's there. His dad's been doing it too. They're in Melbourne. But they do it, and they fit for orthopedic surgeons. And I've seen he's created lifts like this, but typically they can range. The most I've seen so far in our office is 18 millimeters, which is a bit, it's quite a difference. So they talk about leg lengths. When they're off, over time, they're going to wear down that hip socket. All right, so how do we know if you have a subluxation? First thing we do when a patient comes in is we're just going to check their overall posture. So they're going to stand, we're going to check their hip height, compare left to right. We're going to check their bottom of their shoulder blades, top of their shoulder blades, if they have head tilt or not, and then we're going to palpate their spine. So that's posture. Static palpation is just when they're standing there, I'm just going to feel their spine going up. Motion palpation is important. When we see there's misalignment, we want to test the motion of that joint. If it's not moving properly, that's not good. Once we see that, we take a picture of it. As far as chiropractors, there's only 2 views we need to see unless there's something really neurologically going on. We call it, well, it's this view, A to P. We'll see this view, and then lateral will show us if they have forward head tilt, if they have anything going on like this. This will show us if there's tilt or rotation. And the lateral will also show us what phase of degeneration a patient's in. That's how we know if they're phase 1, 2, 3, or 4. And then the other thing that we do, which is when the hips are off, we want to find out what the cause is. So if someone's hips are off, fibrotic tissue has been building up, they could start having pain, discomfort. Typically, that's what brings most patients in is pain. So we're going to check motion and everything. Now we want to know what's the cause. So we look to see, is there indicators anatomical? If there is, we take an x-ray. We do the scan to see if they have foot pronation. If that's, we want to take care of that. And if it's not, and it's just due to bad posture over time that's caused the hips to shift, we're going to adjust, get motion back into those joints, and we're always adjusting back towards neutral. The last thing I like to say as far as adjustments, so you hear people that pop and crack their necks. So what that is, that popping means nothing to us as chiropractors. It just means you push gas out of that synovial fluid. Gas will build up in that synovial fluid, and when it's just like bubble wrap. You push that out, it creates a pop. It doesn't mean anything to us whatsoever, because all we want to feel is movement back into that joint. If there's gas that builds up in there, you're going to hear it. If there isn't, you're not going to hear a thing. And some people get crack happy, where they want to hear that pop, they don't think anything happened. And I tell them some people pop more than others. Don't worry about the pop. When we re-x-ray you, we're going to see those structural changes. But when people pop themselves, they're not doing anything to re-educate that joint. All they're doing is pushing that gas out. Gas builds pressure, so they feel better. And I'll have patients swear to me, they're like, oh, I get this one in every once in a while. I get it right in. And it's hard to tell them, you're not getting, because they want to hear it. You're not getting it in. You're just pushing gas out of that joint, but you could be moving it further out or further into position.
It's like, cracking knuckles. I mean, some people are always cracking, and I mean,
Yeah.
is that good or bad? I mean, it's.
Yeah, that when I went to chiropractic school, that was my first question. Because I was always told, stop cracking your knuckles, you're going to get arthritis. And it's true. I mean, it's just the physics behind it. So if you crack your knuckles and you're pushing into that joint and you keep creating more pressure in that joint and friction, you're going to create arthritis. If you take pressure off of that joint, and we do adjust knuckles, because people, they rotate. The joints rotate, and then there's that long, you're not getting imbibition, and that's osteoarthritis, is wear and tear of the joints. So, yeah.
So it's not good then to do that, like
It's
to
not
crack your
good
neck
to do
or.
this. It's okay to traction out a little bit.
Right.
But you don't want to create hypermobile segments either. You don't want to be pushing way out. You just want enough to get motion back in that joint. So,
But I'm doing the connection between the hands and the neck. I mean, is it not really good to do that? Let your body do it on its own,
no.
rather
so
than.
what
I see
happens-
people going around, trying
Well,
to.
it's not, it's like anything. If a person's trained to do it, it's going to be specific.
Right.
And they're going to be moving it right. They're not trained. They're just pushing. They feel pressure. They get that pop once. They're like, oh, I feel better, because they got the pressure out of the joint. So when I have all these older cousins, my brother's oldest, I was the youngest grandchild, and they were lifeguards at Cape May. And when I'd spend my summers down there, and when they'd come home, it was my grandparents' place, they'd come home, I'd walk on their backs. And I wasn't doing them any good. But I was light, but they'd love hearing that pop. But I'm just pushing. I could be pushing that further out of position, or I could be pushing it closer in position. And it's the same thing, this, if you don't know what direction you're moving,
Right.
it's not good.
Right.
All right, so does anybody have questions? I'm better on time this time, right?
Yeah, good.
That's not okay. So, any questions whatsoever about joints and different problems? Anyone want to discuss any of their issues?
Yeah, I do.
Okay.
And I mean, I've never actually been to a chiropractor. I have friends that go to them and swear by them.
Yeah.
Okay, and 15 years ago, I had a really bad fall. I had a T12 burst fracture and a spinal cord injury.
Okay.
Okay, they took me to Phoenixville. I was there for 8 hours, and then they finally said, you have a T12 burst fracture, spinal cord injury, we're sending you down to Jefferson, which is what they did. And I had an excellent neurosurgeon, but he came to me, he said, I need to do surgery, but if I go in now, you will be paralyzed the rest of your life. So instead, we will put you in, a, what?
traction? Did they
Well,
traction?
it wasn't really traction. It was like I was in a
Brace.
thing for like 9 months, like a
Okay.
like a body cast for
Yeah,
9
okay.
months, and then 3 months with a soft brace.
Okay.
And then I had to do PT, and I started with water PT. And he said, if as long as you're functional and everything, you don't have any pain, then we won't have to do surgery. He said, but we won't know until later.
Yeah.
Okay,
That's
so
cool.
I was doing really well, and I was going over to Valley Forge and doing like prayer walks like 3, 5, 6 times a week.
Yeah.
You know, like 4 or 5 miles, and had good mobility. And recently I've had more pain, and it's more lower back, and I'm starting to get pain going down my legs now too.
Okay.
And I don't want to stop moving,
Right.
because, you know, but I don't know, like, do you have suggestions on even nutritional things? Like, I know that there's a connection. If you're eating things that your body is sensitive to, that's going to increase more inflammation, and the more inflammation, the more pain.
Yeah, and the more degeneration.
And the more degeneration. So, I mean,
Yeah, so
I
that's
just
not my
didn't-
field. I know enough to help people real general, but I will, if they need nutrition, I'll send them to a nutritionist because that's their specialty. But a big part that's really out there is, I mentioned it earlier, omega-3s, because our diet, and corn is in everything. It's in cereal, it's all, they say I forget what percent, but years ago they did a study, if you go to the shopping market, there's so much cornstarch, corn syrup, corn everything. That's an omega-6. That's an inflammatory. So you should have a ratio between and this is just one part of nutrition, but you should have a ratio between your percentage of omega-3 and omega-6, and they say majority of people are so omega-6 that they have all these inflammatory issues, which cause pain. So omega-3, a great source of omega-3 is, remember that commercial, chia? It's the most potent. It's the best form of getting, there's flaxseed oil as opposed to the flaxseed. They say the flaxseed's hard to break down. It's another omega-3. But chia, you can just sprinkle a chia onto your salad. It'll be like pepper. I mean, it tastes like pepper, but the consistency. You can get yogurt, and you can pour a little bit of chia on that and eat the yogurt. Now, if you let it sit long in yogurt, it becomes gelatinous. It's kind of weird. I don't mind it, but some people get grossed out by it. But that's a great source of omega-3s to offset the amount of omega-6s we get.
right.
So that's one area. There's chondroitin. They talk about chondroitin. That's a big thing that goes on. Of course, with any product, it has to be good quality product. So you really want to research. If you just go to a supermarket and get chondroitin, it may not be the most optimal chondroitin. So you want to find out with Kimberton, Whole Foods. They're very educated over there. I do send patients over there.
Right.
There's a lady, a young, well, I guess she's young, it's all relative, but she has brown hair. She's very knowledgeable over there. She works all the time. I don't know her name, but so that's a great area to look as far as nutrition or go to a nutritionist. But
I found curcumin
yeah,
to be really, really good. But as a result, because I had the spinal cord injury, I was always hesitant to go. I mean, because I've heard good and bad about both, and so I'm not trying to bash chiropractors. Okay,
No, that's
there's
fine.
not- okay.
I get it.
No, but
I mean, I
you
literally
know,
get
I've
it.
heard people that have had really, really bad situations
Yeah.
with it, and some that have been really blessed by it. I mean, I have one friend that goes on a regular basis, and she really, you know, feels a difference when she goes.
So
But
there-
so if you have a good chiropractor, that's really, really important.
Well, it is very important, and it's like any profession. Like you have good surgeons, you have surgeons that have killed people. You know,
Right.
you have good doctors, you have doctors that have prescribed bad meds. You know, whatever it can be, it's anywhere in every profession. So, yeah, it's good to go based off of referrals. That's a great way to go to a chiropractor. So if your friends are very happy, that's a great place to go because he's
Yeah.
doing a good job. Now, the biggest thing is make sure, I mean, with your history, he's going to want to see film. I mean, definitely x-ray, but he might want to make sure he sees an old MRI at the very least, depending on how old it is. If you're real symptomatic, you would need to go to your doctor, get a new MRI. These are the kind of things that we do when we see situations that are red flag. Like, okay, make sure, do no harm.
Right.
That's first.
Right.
Yeah, so any profession has good and bad. And it's a shame because I do hear that a lot. Chiropractors, I never go, they're quacks, or they don't even have a real degree. You know, I've heard it all. And we do. I mean, our degrees is as extensive as a medical doctor's, years in school. So,
And I was curious about your tie-in with the asthma too, when you mentioned
asthma, upper
asthma and
thoracic.
allergies. And
Upper thoracic, I've had kids with severe asthma going to the hospital with attacks, and we just check upper thoracic. That's what controls your heart and lungs. It's especially, I mean, it just feels, it's great, so rewarding. So upper thoracic is a big part. It can also be upper cervical. So there's a thing called your sympathetic and parasympathetic and sympathetic. Parasympathetics are upper cervical and lower sacrum. Sympathetics fall in between, and it's a balance. It's like the yin and yang of your nervous system. Parasympathetics are going to slow things down. Mostly, you know, that's majority of what it does. Parasympathetics slow things down. Sympathetics speed things up. So there's that balance. So again, we know just the weight of a dime on that nerve root ganglion, which is right where it exits the spine. Just inside, the same thing. Right inside that area, just the weight of a dime will mess with the transmission of that nerve. So if it's going, if it's in the autonomic, it's controlling how the only way the bronchi are going to constrict and dilate is through that autonomic nerve. So if it's not reacting properly, it's not going to be able, if the brain can't regulate. So there's, a nerve flow is two ways. Let me know if I go too late, because I'll talk forever. So there's what we call efferent, which is nerve transmission that exits the spine, goes to the area, and then that area, whatever organ is, it also sends an afferent message back up. And the brain is constantly coordinating. It's all done in the inner brain. It's going to that's where you release certain hormones and tell the different parts of the body to do these things. And it's all the autonomic nervous system, and the only exit is through your spine. And just depending on how you affect that nerve with the misalignment, depends on how you're going to affect that area. So typically upper thoracic is the area that we see the misalignments with asthma. But it can be cervical. Upper cervical, allergies, so first line defense is going through what you breathe in. So when you have allergens coming into your system, your body needs to react, and it's going to produce, there's a whole cascading event. Usually when I did this talk, I'm real fresh on it. But it's going to respond, and it's going to release certain chemicals which fight off the allergens. So the only way all this can happen is when you breathe it in, it stimulates that area, it sends messages to the brain tells the immune system, all right, we need to send all these mast cells to this area to fight off these allergens. But there's more that goes on. But if you have interference of that transmission going back and forth, and C2 is the big one, that area can't work properly. So again, I don't ever tell any patient we're going to get rid of their asthma or allergies or digestive issues. But what I do is I educate, give them the information about the autonomic nervous system. More importantly, we check the position. If it's off, we x-ray it, we'll see it's off. And then most importantly, we want to make sure there's good motion going on, because you can have a segment that's off, but it's compensating, it's moving properly. You do not want to adjust an area that's moving properly, because then you'll create hyper motion in that joint and instability. Okay. Any questions?
what are your thoughts on like salt caves or massage or use
I
of
don't know
essential?
enough about salt caves. I've heard good things, so it's totally out of my arena. But massage is phenomenal in many ways. It's going to help with lymphatic flow. It's going to help with blood flow. It's going to break up that collagen that lays down within the muscles. Those muscles are linear, and what happens to an injured muscle or overworked muscle is that collagen lays down and it gets interlaced. So instead of that muscle being able to move this way, it interlaces itself and creates a matrix. So now you don't have that motion. So massage is going to help break those up. They talk about fluid. So what happens is when you break that up, your body's going to come in. Red blood cells, white blood cells, white blood cells are going to pick up all the phagocytes are going to pick up all this debris that's not supposed to be in there. They dump it into your lymphatic system, and your lymphatic system flushes out your system. The lymphatic system should be serous, very watery, but what happens when it dumps, it's the same thing when we're sick. We should drink a lot of fluids
Right.
because it's dumping
Healthy
all those.
fluids.
Yeah, lots of good fluid to keep that lymphatic system circulating, and that's why they have you do that. So that's why they have you drink. We suggest people drink water too after an adjustment, especially early on in care, because we're breaking up all those fibrotic tissue. So massage is phenomenal in many ways. Stretching is phenomenal for people. I think yoga is great. There's different types of yoga, so you can't just jump into the advanced stuff, but it's just allowing proper motion within the muscles, the tendons, ligaments, and the joints. Salt caves, I've heard good things. People talk to me about them, but I've never tried one. I'm not against it, I just haven't had time. All right. Well, thank you
Thank
very
you.
much for coming.